From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA, and I'm joined today by Dr. Alexander Walley, who is a professor of medicine at Boston University Chobanian and Abdesian School of Medicine and Boston Medical Center in Boston, Massachusetts. Today, we will be discussing a JAMA article that he co-authored with Drs. Harris and Weinstein titled Medications for Opioid Use Disorder, Opioid Withdrawal, and Opioid Overdose, a Review. This article was published in JAMA on February 11th. Dr. Walley, thank you so much for joining us on this podcast.
Thank you, Dr. Walter. It's a pleasure to be here.
So to start off, could you define opioid use disorder and how common is this condition in the U.S.?
Opioid use disorder involves the compulsive use of opioids that causes substantial distress or impairment at work, school, or home.
And opioid use disorder causes substantial morbidity and mortality. Can you discuss the most recent data about the number of deaths from opioid use disorder in the U.S.?
So the most recent data we have is from 2024, when there were 53,774 deaths from opioid overdose.
And your article presents information about the 3 U.S. FDA-approved medications to reduce unregulated opioid use, and those are Methadone, Buprenorphine, and Naltrexone, and that these medications should be selected based on shared decision-making that considers factors such as availability, convenience, drug-drug interactions, comorbidities, and adverse effects of these medications. Let's start with buprenorphine. Can you discuss this drug's mechanism of action and what are its benefits for people with opioid use disorder?
Sure. The mechanism of action for buprenorphine is it is a partial agonist. And so that means that it occupies the mu-opioid receptor, where it stimulates that receptor enough to treat withdrawal, but actually not enough in most cases to cause euphoria or intoxication. It also occupies that receptor and blocks the effects of other opioid agonists like heroin or oxycodone or fentanyl. So buprenorphine both prevents withdrawal and it also blocks the action of stronger opioid agonists. The benefits include reducing unregulated opioid use. It also improves retention and care. And there's strong observational evidence that it reduces mortality from opioid overdose, and people who are treated with buprenorphine have reduced overall all-cause mortality.
So buprenorphine is often prescribed via the sublingual route. Can you discuss the typical dose of this sublingual dosing and how often is it taken?
The daily dose for sublingual buprenorphine ranges from 8 milligrams to 24 milligrams classically, and that can be taken once a day or in divided doses up to 3 times a day. I will say that in the fentanyl era, which is where we currently are, where most of the unregulated opioids in the U.S. include fentanyl, sometimes doses need to be higher.
And your article discusses that most sublingual buprenorphine formulations are co-formulated with naloxone at a ratio of 4:1. Why is this done?
Yes, that's true. Most of the approved formulations of buprenorphine for opioid use disorder co-formulate it with naloxone at a ratio of 4:1. And this is done because when buprenorphine is consumed sublingually, the naloxone is not active or present. And naloxone, by the way, is an opioid antagonist, which I think we'll be talking about later. And so it's essentially when it's taken as directed under the tongue, it has no action whatsoever. So you might ask, well, why is it included as the co-formulation? The naloxone's really there in an effort to reduce diversion or using the buprenorphine in a way that it wasn't intended, such as injecting it or sniffing it. And so those are ways that people often use unregulated opioids in order to get intoxication or euphoria. And so the presence of the naloxone is really there to discourage those, because if the buprenorphine naloxone formulation is dissolved and injected, the experience that a person will get is likely the opioid antagonist, naloxone, which will cause withdrawal. Hence, the belief is that it will reduce diversion.
And buprenorphine can also be given as a subcutaneous injectable medication, either weekly or monthly. Where is this medication given and who can administer it?
The injectable buprenorphine, which is not co-formulated with naloxone, by the way, just on its own, that can be administered, as you said, weekly or monthly. And because it's a controlled substance, it can only be dispensed to a healthcare provider who would be administering it. So people need to go into a clinic in order to receive the weekly or monthly injections. As far as where on the body the injections occur, they can be around the umbilicus or in the arm or in the leg or in the gluteus.
And can you just discuss some adverse effects of buprenorphine?
The most important adverse effect is because it's a partial agonist and not a full agonist. If it's administered at a time where it's proximal to where somebody last used unregulated opioids, like if somebody used fentanyl or heroin or oxycodone in the last, say, 6 hours, taking the partial agonist, buprenorphine, so close to the time when the last unregulated opioid was used can actually precipitate withdrawal because the buprenorphine can displace the full agonist from the opioid receptor and cause a relative diminution in activity at that opioid receptor. And in fact, with fentanyl, because it's lipophilic and really can build up in the body's tissues, we believe that oftentimes the gap between the last fentanyl use and the first standard buprenorphine dose has to be up to 72 hours. And so precipitated withdrawal is the most common adverse event that we think about. Other adverse events are those that are typical of opioid agonists. So people can have endocrine abnormalities, menstrual irregularities, or reduction in testosterone. Those are less common. So those are the adverse events that I think of most often.
Great. And moving on to methadone, can you describe this drug's mechanism of action and what are its benefits for people with opioid use disorder?
Methadone is a full opioid agonist. It treats withdrawal. So that provides relief in the short term for people who are in opioid withdrawal. Once people have stabilized on their methadone dose, it will block the action of opioid agonists that are taken on top of it, like fentanyl, oxycodone, or heroin. And it will also reduce craving, so people will not have as much of a drive to use opioids as they would. One of the things that's notable about both methadone and buprenorphine is they're long-acting, and so they can be dosed once a day and keep people comfortable throughout the day, comfortable really and productive throughout the day.
And is there evidence that methadone affects mortality and overdose?
Yes, so similar to buprenorphine, actually with more time studied and more studies, methadone has a very strong association with a reduction in overdose death and improvement in all-cause mortality. It also benefits people through reducing their use of unregulated opioid agonists, as well as improves retention in substance use care and other care.
And in the U.S., outpatient treatment with methadone is delivered through these structured, licensed opioid treatment programs, which are typically located in facilities separate from other healthcare settings. Can you describe the common doses of methadone? And does the dose vary based upon the specific opioid that an individual is using, such as heroin or fentanyl?
Sure. So historically, the doses are initiated at lower dose than people are eventually stabilized on. And that's because methadone, first of all, has a long and somewhat unpredictable half-life from person to person. And so the doses need to be individualized. And if you initiate somebody on a dose that they eventually need to be on, you'll have accumulation of that dose. And there's a risk actually for oversedating or overdosing people. So you have to start with a lower dose of methadone than you eventually maintain people on, and you have to titrate it over time. And so a starting dose historically has been 30 to 40 milligrams, and then we titrate that up over days to weeks to 80 milligrams or higher. you asked about specific opioids. It is true that fentanyl is a faster acting, more potent opioid. It's now the most common opioid that is involved in opioid overdose deaths and is a big part of the unregulated drug supply. And so for fentanyl, we're seeing that we need to initiate people often at doses higher than 40 milligrams, like 50 or even 60 milligrams. And then we titrate people up to usually a little bit higher dose, at least 100 milligrams. Now, there's no ceiling on the dose of methadone that people will eventually end up on. So some people need to be on doses up above 200 milligrams in order to really control their cravings and to achieve blockade.
And your article mentions that another risk of methadone is QTC prolongation, which can increase the risk of torsade de pointe and sudden death. How often does this QTC prolongation occur, and who is at higher risk?
Epidemiologically, we don't actually know how common torsade de pointe is, but we do know that prolonged QTC is quite common. And so the significance of that prolongation is something that I think is still not clearly worked out. However, it is important for people being treated with methadone, especially those with underlying risk factors for cardiac arrhythmia, including long QT, such as congenital long QT syndrome, to have their QT measured and monitored along with the methadone dose titration. This is not an issue for the great majority of people on methadone. And so it is important that we, for the general person seeking treatment that doesn't have risk factors, that we don't exclude them from care by requiring a baseline EKG. So baseline EKGs are not recommended if they're going to be a barrier to initiating care.
And what is the evidence about the efficacy of buprenorphine versus methadone for the treatment of opioid use disorder?
They both have very similar benefits when it comes to reducing opioid use, when it comes to retaining patients in care, and when it comes to associations with reductions in overdose death and all-cause mortality. The one area where it appears that methadone has the advantage is in retention in care. And this is an issue overall with medications for opioid use disorder. The medications are very effective, but they're only effective when people take them. And when people stop or discontinue medications for opioid use disorder, they are at risk of returning to opioid use. And when they return to opioid use, they're at very high risk for overdose and resuming the consequences of their opioid use disorder. So yeah, the one area I think there's an advantage for methadone is with retention.
The third medication your article mentions is Naltrexone. Can you describe this drug's mechanism of action and its benefits for people with opioid use disorder?
Sure. So Naltrexone is a competitive opioid antagonist. It has a higher affinity for the mu-opioid receptor than full agonists like heroin, oxycodone, fentanyl, or methadone for that matter, but it has no activity at the opioid receptor. And so what that means is that like buprenorphine and methadone, it is a blocker. So if it's on board, then the patient is not going to feel any of the euphoria or the agonism from an opioid agonist like heroin, fentanyl, or oxycodone. It also will reduce craving if it's taken as it's designed. Where it's different from methadone and buprenorphine is it will not treat withdrawal in the short term. It will actually precipitate withdrawal. So I talked about precipitated withdrawal when buprenorphine's taken, too close to the last unregulated opioid use. Well, naltrexone, you have to wait 7 to 10 days before you can initiate it. So that washout period, somebody has to be completely abstinent from opioids. And that's where the real challenge is in starting naltrexone, is that for people with a severe opioid use disorder, it's very difficult to get them to a point where they've been opioid abstinent for 7 to 10 days so that we can initiate the naltrexone without causing precipitated withdrawal.
Great. And can you describe how naltrexone can be administered, either orally or as a long-acting injectable?
Sure, exactly. There's two options. The one that was initially available was oral administration. And so the starting dose is 50 milligrams, and that's really the target dose. For patients who get some benefit, you can go up to 100 milligrams if the patient and provider decide to. So that's daily oral dosing, one pill once a day. Injectable naltrexone is administered once every 28 days with an intramuscular injection. It requires refrigeration and mixing. And so for those reasons, even though it's not a controlled substance like injectable buprenorphine, it is administered in the clinic, typically by a nurse. Those are the ways they're administered: monthly for the injectable and daily for the oral tablet.
And is naltrexone use associated with a decrease in opioid-induced mortality?
No, we don't have enough data about naltrexone and mortality, either overdose mortality or all-cause mortality. Part of that is because in real-world samples, there's just been fewer people that have been treated with naltrexone. And also, when people are treated with naltrexone in real-world samples, they tend to have less retention than they do on buprenorphine or methadone. And so to see, I think, an overdose or a mortality benefit, we're going to need more time and perhaps formulations that improve retention or methods that improve retention on naltrexone. I also want to mention just the differences between the benefits of injectable naltrexone and oral naltrexone. There's been a Cochrane review that concluded that oral naltrexone for opioid use disorder is no better than placebo. And so that's important for providers to understand. I still think it's an option for patients. It is FDA approved, but the evidence for oral naltrexone is not as strong as it is for injectable naltrexone, where RCTs and systematic reviews have shown that there is improvement in unregulated opioid use and actually retention and care, as well as opioid craving with injectable naltrexone.
And people with opioid use disorder who abruptly stop taking opioids develop withdrawal symptoms. Can you describe some common opioid withdrawal symptoms?
Patients that I have cared for describe the worst flu you've ever experienced. So that's, from a patient's perspective, what they feel. What that means is body aches, headaches, nausea, vomiting, lots of anxiety and irritability, as well as loose stool and hard time controlling it. So that's the experience people have. Not life-threatening in most cases, but it's really a feeling that is very terrible, and it's very motivating. So people who are in opioid withdrawal and connect that to their abstinence from opioids, they are going to be very motivated to resume taking opioids to relieve those withdrawal symptoms. And so that's driving a lot of the chronic use despite adverse consequences that defines opioid use disorder.
And how long do those withdrawal symptoms typically last?
Generally, they last days to weeks, and it tends to be more days for the short-acting opioids like heroin and more into weeks for the longer-acting opioids like methadone.
Which classes of medications are commonly used to treat opioid withdrawal?
Well, the best medication to use to treat opioid withdrawal are opioids. And specifically, I'm talking about, depending on the clinical setting, so in outpatients or in standalone medically managed withdrawal programs, we typically use methadone or buprenorphine. If the patient's open to it, we treat the withdrawal and then initiate that medication and continue it in the treatment. But if the patient is in an inpatient setting where they may have other medical issues going on or want to transition, for example, to naltrexone, in the short term, we can use short-acting opioids in the hospital if that's what's best medically for the patient. So I'm talking about hydromorphone or oxycodone or morphine. And so, depending on the setting, you have a choice of what opioid you would use. Other classes of medications that treat the symptoms of opioid withdrawal are symptomatic relief. So there's one FDA-approved medication called lofexidine, which is an alpha-2 agonist medication. It has a cousin, clonidine, which is commonly used in medically managed withdrawal programs. For the GI side effects, you're going to be using antiemetics like Danzatron. For loose stool, loperamide. And for body aches, using ibuprofen. For stomach cramping, dicyclamine. And for the anxiety and insomnia, we often use antihistamines like hydroxyzine or diphenhydramine.
Your article also discusses the use of naloxone to treat opioid overdose, which causes respiratory depression, unconsciousness, and may lead to respiratory arrest and anoxic brain injury and death. Can you discuss the various routes of administration of naloxone?
Sure. So naloxone is the antidote to an opioid overdose. It is a short-acting and direct opioid antagonist. It will outcompete almost all opioids for the opioid receptor. And by doing that, it removes all stimulation of the opioid receptor and removes the overdose, the respiratory depression, and sedation. So you asked me about the routes of administration. So historically, naloxone was administered by injection, usually intramuscularly, although it can also be administered intravenously or subcutaneously. With the rise of community naloxone distribution, there has been the development of nasal formulations, so nasal sprays, and these are now widely distributed as methods for community overdose rescue. Naloxone can also be administered through the ET tube, and so the dosing for those injectable versus intranasal is different because of the bioavailability. So the typical community dose of naloxone administered intramuscularly would be 0.4 milligrams intramuscularly, whereas the intranasal dosing would be either 3 or 4 milligrams. There's formulations that have those doses. In those doses, that's essentially your starting community dose of naloxone, and those are all considered effective and largely similar in their impact.
Before closing, is there anything we didn't discuss in this podcast that you'd like to mention?
There is one piece I want to draw attention to for the American audience, which is that there are choices, especially for medication for opioid use disorder, that are available in other countries that we don't have available in the United States. And I really believe that the future of us making progress in caring for people with opioid use disorder is to provide them with more choices. And so those other choices include sustained release oral morphine, which is available in Canada and many countries in Europe. There's also, in some cases, treatment with long-acting fentanyl, like fentanyl patches, is also used in other countries, as well as injectable opioid agonists like injectable hydromorphone or injectable diacetylmorphine, which is actually heroin. So not legal in the United States at this time, but for people who are not able to get better with the current choices like methadone or buprenorphine, these injectable opioids have shown to be effective in randomized controlled trials in other countries, and it is available in several other countries, again, in Europe and in Canada.
Thank you so much for sharing your thoughts with us about this interesting and very important topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Alexander Walley from Boston University Chobanian and Abedisian School of Medicine and Boston Medical Center. You can find a link to the JAMA review article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.